Proteinuria is more than just a lab finding, it's a key indicator of kidney health and disease. Let's dive into how the kidneys handle proteins, the types of proteinuria, and the clinical significance of assessing protein and albumin levels. But before we dive in, I'd like to thank everyone who has liked the video and subscribed to the channel. However, I noticed that percentage has dropped to 71.8% of viewers that are still not subscribed. We still need your support. If you're watching this and haven't subscribed yet, I invite you to hit that subscribe button now. And for those of you who've already benefited from our tutorials, please don't forget to give this video a thumbs up to show your support. Let's get started. The kidneys play a precise role in managing proteins. High molecular weight proteins stay in circulation, thanks to the selective filtration of the glomerular filter. Low molecular weight proteins, on the other hand, are filtered, reabsorbed, and broken down in tubular cells. This delicate balance ensures that minimal protein is lost in the urine under normal conditions. Proteinuria has been linked to kidney disease for over 2 centuries, dating back to Bright's description of albuminous nephritis in the early 19th century. Significant protein in the urine is not just a marker of renal dysfunction, it's a warning sign of potential progression to chronic kidney disease. Proteinuria can take various forms, each pointing to different underlying mechanisms. Glomerular proteinuria arises from defects in the glomerular filter, allowing larger proteins like albumin to pass through. Tubular proteinuria occurs when tubular cells fail to reabsorb filtered proteins. Overflow proteinuria results when excessive low molecular weight proteins, such as Bence-Jones proteins in myeloma, overwhelm the kidney's reabsorptive capacity. Why does proteinuria matter? It's a strong predictor of progressive kidney disease. Reducing protein excretion is crucial, not only for slowing disease progression but also for improving overall patient outcomes. Accurate measurement of total protein and albumin in urine is key to diagnosing and managing proteinuria. It helps determine the type and severity of kidney involvement, guiding clinicians toward targeted treatment strategies. The gold standard for quantifying proteinuria is a 24-hour urine collection. But for convenience, alternatives like overnight, early morning urine, EMU, or random samples are also effective. Spot testing with the protein-to-creatinine ratio, PCR, or albumin-to-creatinine ratio, ACR, simplifies testing, adjusting for urine concentration variability and correlating well with 24-hour collections. EMU samples are preferred for their reliability and insensitivity to orthostatic proteinuria. Random samples work when EMU is unavailable, and low results effectively rule out significant proteinuria. To estimate daily protein loss, multiply the PCR or ACR in mg per millimole by 10, assuming an average creatinine excretion of 10 millimole per day. Diagnosing proteinuria or albuminuria requires consistent evidence of increased albumin loss across at least 2 of 3 samples, after ruling out acute factors like infections or metabolic crises. For diabetes, screening begins 5 years after diagnosis in type 1 diabetes and at diagnosis in type 2 diabetes. Tests are done annually until age 75 to monitor kidney health. Persistent albuminuria demands follow-up testing to confirm and exclude other causes like orthostatic proteinuria, urinary tract infections, or heart failure. Proper sample handling ensures accurate results. Analyze fresh samples whenever possible. If storage is necessary, refrigerate at 4 degrees Celsius for up to a week. For extended storage, freeze at -70 degrees Celsius to prevent albumin degradation, as freezing at -20 degrees Celsius causes significant protein loss. Always bring samples to room temperature and mix thoroughly before analysis. The detection of proteinuria has both prognostic and therapeutic implications. In diabetes, optimizing metabolic control is critical before testing for albuminuria. And remember, albuminuria within the first 5 years of type 1 diabetes is rare. Consider other kidney diseases if it's detected. Measuring total protein in urine is essential for assessing kidney function, but it's a complex process with unique challenges. Several methods are used to measure total protein in urine, each with its own approach. The Lowry method, a biochemical standard. Turbidimetric assays using trichloroacetic acid, sulfosalicylic acid, or benzethonium chloride. Dye-binding methods with Kumasi brilliant blue, pyrogalol red molybdate, or pyrocatecholviolet molybdate. These methods provide flexibility but face challenges in precision and sensitivity. Measuring proteins in urine is no simple task. The hurdles include extremely low protein concentrations, often just 100 to 200 mg per liter. High variability in protein composition across samples. The presence of interfering substances, such as non-protein compounds and inorganic ions. These factors significantly impact the precision and accuracy of measurement methods. In modern laboratories, benzethonium chloride and dye-binding methods are popular due to their adaptability for automation. Turbidimetric assays, while effective, face challenges at high protein concentrations due to the antigen excess effect. However, monitoring turbidity formation rates can help mitigate this issue. Not all methods are created equal when it comes to specificity. Most methods respond more strongly to albumin than to globulins or other proteins. Modifying pyrogalol red reagents with sodium dodecyl sulfate, SDS, enhances sensitivity to non-albumin proteins. However, significant variability exists, especially when measuring low molecular weight proteins or samples with low total protein concentrations. Interferences can skew results, leading to false positives. Common culprits include aminoglycosides, a class of antibiotics. Non-visible hematuria, or microscopic blood in urine. Modified gelatin solutions, used as plasma expanders in clinical settings. Selecting the right method is crucial. Turbidimetric and dye-binding assays, along with urine reagent strips, have varying specificity and sensitivity to different protein types. For accurate results, consider the type of proteins being measured. Potential interferences present in the sample. Urinary total protein measurement faces a significant challenge: lack of standardization. Assays respond differently to protein properties, which vary among urine proteins. No reference measurement procedure is recognized by the Joint Committee for Traceability in Laboratory Medicine, JCTLM. Without standardized reference materials, metrological traceability remains unattainable. Variability between laboratories is a recurring issue, stemming from differences in analytical methods. Calibration standards. Interestingly, this variability decreases at higher protein concentrations, where albumin dominates. Calibration is another hurdle. While urine protein calibrators help reduce discrepancies, they are limited by nonlinear assay responses. Differences in protein composition across samples. This makes precise calibration an ongoing challenge. Given the challenges with total protein assays, urine albumin has become the preferred analyte for assessing proteinuria. It offers greater consistency, reliability, and clinical relevance, particularly for monitoring chronic kidney disease and related conditions. Measuring urinary albumin is a cornerstone of kidney health assessment, with advancements dating back to the 1960s. The 1960s marked the beginning of urinary albumin measurement using immunoassays. Today, immunoturbidimetric and nephelometric assays are widely used for their ability to detect albumin at concentrations as low as 2 to 5 mg per liter. Despite their sensitivity, significant discrepancies persist among commercial assays. Light scattering methods can produce falsely low readings at high albumin concentrations due to a phenomenon known as the prozone effect. To counter this, laboratories retest high-protein samples and use antigen addition protocols for more accurate results. Modern dry chemistry systems simplify albumin measurement. These devices use gold-labeled antibodies that bind to albumin, producing a detectable pink coloration in the detection zone. Additionally, point-of-care testing with portable devices offers quick and convenient urinary albumin analysis, often integrated into reagent strip testing systems. Traceability in urinary albumin measurement remains a work in progress. Currently, no official reference measurement procedure or higher-order reference material is recognized by the Joint Committee for Traceability in Laboratory Medicine, JCTLM. Most assays calibrate using a serum-based standard recommended by CTIGO. However, assay bias is a persistent issue. A recent evaluation of 17 commercial assays revealed plus or minus 20% bias at 30 mg per liter albumin and plus or minus 10% at 300 mg per liter. These variations stem from nonlinearity, imprecision, and differences in analytical specificity. Bias and inconsistency remain challenges due to albumin instability, caused by polymerization, fragmentation, and degradation during storage or freeze-thaw cycles. The lack of robust reference materials to align results across different platforms. Earlier claims suggested the presence of non-immunoreactive urinary albumin, attributed to coeluting proteins in size exclusion HPLC. However, more recent studies have largely refuted these findings, confirming the accuracy of immunoassay-based albumin measurements. The reference interval for urinary total protein loss typically ranges from 150 to 300 mg per day, depending on the laboratory. Normal protein loss is often expressed as a protein-to-creatinine ratio, PCR, of approximately 15 mg per mole. For albumin, healthy individuals excrete less than 30 mg per day, alongside smaller proteins and tubular secreted proteins, like Tam-horseful glycoprotein, THG. Proteinuria is commonly detected using reagent strip tests, with clinical significance indicated by a result of plus or higher, roughly equivalent to 300 mg per liter or a PCR of 50 mg per mole. According to CTIGO guidelines, albuminuria is classified into three categories. A1, normal or mild, with an ACR of less than 3 mg per mole, 30 mg per g. A2, moderate, ranging from 3 to 30 mg per mole. A3, severe, exceeding 30 mg per mole. Gender-specific cutoffs, like 2.5 mg per mole for men and 3.5 mg per mole for women, are still used in regions like Australasia. Urinary albumin loss is highly variable, influenced by factors like exercise, posture, time of day. With in-person variability, or CVI, ranges from 4% to 103%, with a median of about 33% for the albumin-to-creatinine ratio, ACR. Early morning urine, EMU, samples are preferred for their lower variability, and expressing albumin relative to creatinine improves accuracy. Variability in albumin handling may be influenced by genetic factors, like mutations in the cubulin gene. Creatinine excretion, which varies by age, gender, and muscle mass, also affects thresholds for ACR and PCR. This can lead to false positives or negatives in individuals with extreme muscularity. Proteinuria can be measured using reagent strips or laboratory tests for total protein or albumin. Reagent strips estimate protein concentration based on urine concentration, but results can be affected by hydration status. While they provide a rough indication, reagent strips are not reliable for diagnosing pathological proteinuria. Laboratory tests, such as the protein-to-creatinine ratio, PCR, or albumin-to-creatinine ratio, ACR, offer greater accuracy. Studies highlight significant limitations of reagent strips. In a rheumatology outpatient study, reagent strips failed to reliably detect protein loss of 300 mg per day. A pooled obstetric study reported low predictive value for detecting significant proteinuria during pregnancy. Due to their high false negative rates and poor predictive value, organizations like CTIGO, NICE, and NACB recommend against using reagent strips for proteinuria screening. Positive reagent strip results should always be confirmed with laboratory tests like PCR or ACR, using an early morning or random urine sample. This ensures accurate quantification and helps guide further clinical investigation. In the context of preeclampsia, proteinuria is defined as greater than 300 mg per day or a PCR of greater than 30 mg per mole. Currently, there's insufficient evidence to replace total protein testing with urinary albumin measurement in this scenario. In most cases, proteinuria reflects albuminuria, making urine albumin testing a potential replacement for total protein testing. Albuminuria is strongly associated with cardiovascular mortality, progression of kidney disease, especially in diabetes. It is also a sensitive marker for detecting glomerular pathology associated with systemic diseases like hypertension and systemic sclerosis. In healthy individuals, normal urine albumin loss is less than 30 mg per day. Total protein assays are less precise at detecting these low concentrations. Albumin increases may occur without significant changes in total protein levels. For example, a study found that 63% of samples with elevated albumin loss, greater than or equal to 25 mg per day, showed no significant increase in total protein loss, greater than or equal to 250 mg per day. In diabetes, increased urinary albumin loss is a well-recognized marker of declining renal function. Both European and US guidelines recommend routine albuminuria screening for type 1 diabetes 5 years after diagnosis. Screening for type 2 diabetes at diagnosis. These recommendations are supported by sensitive albumin assays, validated treatments such as ACE inhibitors or ARBs, cost-effectiveness demonstrated in clinical trials. Albuminuria is common, not just in diabetes. Its prevalence includes 7.8% in the US, NANS 3. 6.8% in Australia. 7.2% in the Netherlands, with lower rates after excluding diabetes and hypertension cases. In high-risk groups, 28.8% of individuals with diabetes. 16% of those with hypertension. Research links albuminuria to cardiovascular and non-cardiovascular morbidity and mortality, especially in older adults and those with kidney disease. Meta-analyses from the CKD Prognosis Consortium reveal strong associations between increasing ACR levels and all-cause mortality. Cardiovascular mortality, kidney failure, AKI, and CKD progression. Even low levels of albuminuria, once considered normal, are now recognized as significant risk markers. While the risks of albuminuria in diabetes are well established, limited data exist on interventions like ACE inhibitors or ARBs in non-diabetic individuals with albuminuria. Further research is needed to determine the effectiveness of such treatments in these populations. And that is all for today. See you in the next video, Quantitative Assessment of Proteinuria, Other Urinary Proteins. Thank you for watching and good luck.